Hello, this is Dr. Oviedo. Today we are going to review dilated cardiomyopathy, myocarditis, hypertrophic cardiomyopathy, and arrhythmogenic right ventricular cardiomyopathy. The first slide is normal heart. This is reviewed in a separate video. Case 1 is dilated cardiomyopathy. The heart on the left has dilated cardiomyopathy and the heart on the right is normal. Let's take a look at the heart on the left. This is the right atrium. I can tell because the wall is very trabeculated. This is the right ventricle. This is the left atrium. I can tell because the wall is quite smooth. And this is the left ventricle. You can see the left ventricular chamber is quite large and also has an abnormal globular shape. When I look at the normal heart on the right, this is the left ventricular chamber that I'm outlining right here. You can see it has a normal shape, and when you compare the heart on the left, this heart has a globular appearance when compared to the normal heart on the right. You will remember from the lecture that dilated cardiomyopathy has numerous etiologies, and you can't tell the etiology by looking at the gross specimen. In order to determine etiology, you need a clinical history such as a toxic exposure, or you can also do genetic studies. Let's go on to the next case. Case 2 is myocarditis, which is one of many etiologies of dilated cardiomyopathy. Let's orient ourselves. Going from outside to inside, down here, this is epicardium. This entire area here is myocardium, and the lining, of course, is endocardium. I'm going to take a closer look right here. At this power, you can see a lot of inflammatory cells. There are inflammatory cells right here, and right here. There are quite a few, and they are infiltrating the cardiac myocytes. Some of these cells are neutrophils. The ones with round nuclei, for example, right here, are lymphocytes. The ones with lobulated nuclei, for example, right here, are neutrophils. This is the appearance of myocarditis. Let's go on to our next case. This slide is normal interventricular septum. The purpose of this slide is to compare to the next case. You can, of course, see normal endocardium here on the left and normal endocardium here on the right. This is, of course, interventricular septum. Let's take a closer look right here. This is the appearance of normal myocardium on longitudinal section. You can see there is a slight branching of the myocardial cells. You can see the slight branching right here and right here. If you look carefully, you will see that there are other areas of branching which I am not pointing out. In addition, you can see centrally placed nuclei. You can see this right here and right here. This is the appearance of normal myocardium. Case 3 is hypertrophic cardiomyopathy. Let's orient ourselves. This right here is the right atrium. This is the right ventricle. This is the left atrium. And this is the left ventricle. You can see the left ventricle is very, very thick. The distance from here to here is much thicker than you would see in a normal heart. The interventricular septum is also very, very thick. It goes from here to here. It appears to be even more thickened than the free wall of the left ventricle. This is called asymmetric septal hypertrophy. In addition, you can see the left ventricular chamber right here is quite small. The left interventricular septum is also blocking the outflow tract of the left ventricle. Let's go on to the histology. Please ignore the dots on this slide. This is interventricular septum. There is endocardium up here, and there is endocardium down here. I'm going to take a closer look in this area right here. At this power, you can see the individual cardiac myocytes are much larger. This can be hard to appreciate, but the distance from here to here is much wider than it should be. These cells also have larger nuclei than normal. You can see this nucleus here and here is much larger than it should be. You can also see there is an irregular branching pattern. This can be kind of hard to appreciate, but if you look at this slide as a whole, the branching appears to be more irregular when compared to the normal heart. This, of course, is the appearance of hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is autosomal dominant and can be caused by different mutations of sarcomeric proteins. These mutations cause enhanced contractility with impaired relaxation, and the myocytes respond to the abnormal function with hypertrophy. You can also get fibrosis. If you did a trichrome stain, you could probably see the fibrosis in this case. Okay, let's go on to our next case. Case 4 is arrhythmogenic right ventricular cardiomyopathy. This is a cross-section of the heart. You can see this is the left ventricle. This here on the right is the right ventricle. You can see the chamber is much too large. In addition, if you look at the wall of the right ventricle, here where I'm going over with my cursor, you can see it is almost entirely composed of adipose. There is very little normal cardiac muscle on the right ventricle. This is the appearance of arrhythmogenic right ventricular cardiomyopathy. This is autosomal dominant and is caused by various mutations that affect desmosomal proteins. These desmosome mutations affect cell-cell adhesion, and this can lead to myocyte death and fatty replacement. Please note that adult hearts will frequently have adipose on the right ventricle. However, underneath the adipose, there will be normal myocardium, unlike what we are looking at here, which is almost all adipose. Okay, let's go on to our summary slides. The first slide is normal heart, which is reviewed in a separate video. Case 1 is dilated cardiomyopathy. Here is our heart. Here is the normal heart for comparison. This is the right atrium. This is the right atrioventricular valve. This is the right ventricle. This is the left atrium. This is the left atrioventricular valve. And here is the left ventricle. You can see the chamber is too large and also has an abnormal globular appearance. Here on the right, I've outlined the normal heart left ventricle chamber for comparison. If you compare the shapes, you can see the dilated cardiomyopathy is larger and more round or globular than the normal heart. Case 2 is myocarditis, which is one of the many etiologies of dilated cardiomyopathy. Here is our section. Here's the endocardium, this is the myocardium, and this is the epicardium. At high power, you can see there are lymphocytes and neutrophils infiltrating the myocardium, which is, of course, the appearance of myocarditis. The next slide is normal interventricular septum. This is simply for comparison to the next case. Case 3 is hypertrophic cardiomyopathy. Here is our heart. This is the right atrium. This is the right atrioventricular valve. This is the right ventricle. This is the left atrium. This is the left atrioventricular valve. And this is the very abnormal left ventricle, which demonstrates massive hypertrophy with asymmetric septal hypertrophy. You can see the left ventricular chamber is quite narrowed. Here I've outlined the hypertrophied left ventricle in yellow with the very narrowed chamber in red. You can also see the septal hypertrophy will cause outflow obstruction. Here is the histology. You can see there are enlarged nuclei, very thick myocytes, and disorganized branching. Case 4 is arrhythmogenic right ventricular cardiomyopathy. Here is our heart. This is a cross-section. This is the left ventricle. This is a very large right ventricular chamber. You can see the right ventricle wall is largely replaced by adipose. This is the appearance of arrhythmogenic right ventricular cardiomyopathy. Okay, that's it.